Well, it's truly a pleasure to have two gurus on social media and healthcare, including the first Indian radiology general, whatever he calls himself, who has been a frequent guest on Healthcare Unfiltered, and a new guest, Adam Gaffney, who I followed his work for a long time and certainly a big fan. Sometimes I agree with his views, sometimes I won't, but the good news is I will not provide any of my views today. In fact, I will be moderating a discussion between Adam and Saurabh, talking about the payer model and the payer system in the United States, if we can ever agree on a better model or a best model, and really how does these approvals that the FDA bring in, how do they actually fit within any of the models we propose? Okay, so I will do more moderation, less talking, I promise, except in the beginning. And if you're hearing some sound, there's a thunderstorm outside of my window, so hopefully this will not really impact the taping. Adam, you start first, a little bit about you as to who you are and what you do and how did you get involved into healthcare policy and so on for folks who don't know you.
Sure. Well, first, thanks so much for having me on the podcast, and it's good to be joining both of you. So yeah, my background is clinically in pulmonary and critical care medicine. I mostly work in an ICU in a sort of community academic hospital right outside Boston. I'm at Harvard Medical School. I do a fair amount of health policy research, but I also have background in advocacy. So I was president of Physicians for a National Health Program, which is a Medicare for All nonprofit advocacy organization up until last year. So I sort of combine clinical practice in my career. I combine health policy research, some non-academic writing, some posting, and some advocacy as well.
You're a great writer, you're a prolific writer, but can I ask you what got you into policy? Is this something that you acquired as you progressed in your career, or were you like, what got you interested in healthcare policy?
I would say that politics brought me to policy. I've always been interested in history, political change. I've always had a very progressive political orientation going back to high school. And so I think it made sense for me when I decided on a career in medicine that the way to go about changing the world would be in one small way, which would be in the healthcare sphere. And so that's probably why I come at it. Great.
Saurabh, many of my listeners know you. You've been on the show before, but maybe a refresher as to who you are, what you do, and also what got you interested. You do write a lot about healthcare policy in general and a little bit of politics. What got you into that?
Well, thanks, Chadi, for the invitation, and great to talk to Adam, who I admire tremendously for his single-mindedness about single-payer system. I actually trained in a single-payer system, Britain's NHS. Technically, it's a two-tier system, which I'll get to. And then I migrated to the United States because I changed my stream from surgery to radiology. And so I have two interests. One is radiology, specifically cardiovascular imaging. And the other is the kind of whole socio-political elements altogether. It was hard not actually having that interest, because when you come to the United States, you realize there's a lot of conflict over here, there's a lot of tension over here. And depending on your point of view, I find it fascinating. And so that, just looking at it from an outsider's point of view, has just been very, very interesting. There are very few countries in the world where forces come colliding with each other. And I know people talk about polarization as if it's a bad thing, but I think that it also exposes a certain element of society that is very healthy, which is that if you're not going to have these clashes, you're not going to make progress. And so America very much is a country of a clash. So I like that.
So let's start by level setting for listeners some definitions, because when we talk, and Adam, I'll ask you first, when I say the word single payer system, am I talking just Medicare for everyone? Because obviously we know the criteria to be in Medicare right now. But if I'm saying single payer system, I'm saying Medicare for everyone from the time they become independent of their parents, until the day they die. Is that what we're talking about?
That's the usual sense of the term. I think, we often use as a model the Canadian system, which is basically a single payer system. You enroll effectively 100% of the population in a single plan. Now, each province has its own plan to some extent, but it's basically one national system for the most part, with some variation. And so, yes, I think that is the concept. It would be a plan like Medicare, but for everyone. I would say that, the kind of single payer plan that, we propose in Physicians for National Health Program, and that has been described in some of the legislation that's in Congress for a number of years, actually tries to go beyond some of the existing models and ensure no cost sharing, no out-of-pocket payments for doctor visits and hospitalizations and prescription drugs, and also to change the way we pay hospitals and the way we finance hospitals, not just who pays but how pays. So I would say that the sort of bare minimum definition is one payer, one government payer that covers everyone, but that there's a variety of things you can do in addition to that can achieve greater efficiencies and greater equity.
So Adam, and in terms of the government of a particular country, so this will be the federal government of the United States, or that will cover the healthcare cost of patients. So where would they get the money from? Like taxes, or is it state level or federal level, or how does that work? Just to get level set before Saurabh comments on that.
Sure. Well, I think it's worth, for the purpose of this conversation, focusing on the federal model. I mean, people have proposed state level single payer plans. There's some bills. There are certain policy complications there. It's not impossible. Canada started with province level single payer and expanded to national, but it may be simpler for the purpose of the conversation to stick with one archetype. So yes, under that archetype, you basically tax finance the vast majority of healthcare expenditures. And so you might say that's a huge amount of money, and it is, but keep in mind that currently about 2/3 of healthcare spending in the United States is already publicly financed, which sounds like more than you might think. But if you add up Medicaid plus Medicare, plus the Veterans Administration, plus the Department of Defense, plus the Indian Health Service, plus the tax subsidization for private health insurance, plus the private health insurance premiums for public employees at the state, federal, local level. If you add all that up, we're currently tax financing about 2/3. So it isn't quite as big of a leap as it sounds.
So Rob, what's wrong with that? Anything?
Well, I think, the idea is good. And personally, I don't have any objections to the idea. And also, as Adam said, he's actually not, he's actually being generous to the current system. The current system, the administrative costs are phenomenal because everybody has to build an insurance company. So if you take that away, that would just dramatically reduce some of the waste costs. There are a few things to understand about single payer from a country that actually does the single payer. The first is that it is a single financing system, but it's not simply a case of, well, here's this blank check and all your hospitals should just come up and take whatever you want and whatever. There are needs based on population, and there's actually a process, a commission at the moment where local GPs get a wad of cash for their local authority. And so it's not simply a case of, you just put your bank card in the ATM and get money for what you need. Brixton, for instance, has a certain budget. Milton Keynes has a budget determined by their GPs. And as you can imagine, determined by multiple things, including the socio-economic status of the people in those regions. We all know that there's been a long-standing relationship, not a terribly good one, but an unfortunate one between socioeconomic standing and the actual consumption of healthcare. And so what you have is you're not going to get rid of equity. So what I want to do over here is push back on some of the misconceptions of what a single payer delivers. You're not going to get rid of the equity. If you go to London and you go to various hospitals, there's one in Chelsea and Westminster, which is like an American hospital. It has fountains and it has gardens. And then there's one in East London that's like hospital in India, because that's where the budget is. All the clever people want to go to Chelsea and Westminster, and people that don't have that good grades and references go to the one in East London. So you're not going to get rid of this inequity. So if that's your motivation, then I'm afraid you're going to get a bit disappointed. And yes, there is financing, but again, it's like a central financing that is decentralized. The third point I want to make over here, have I made two or just one?
Yeah, but Saurabh, I think the second point you made is similar to the state level, which I believe Adam was trying to shy away, because then you could look at states that serve an underrepresented minorities, and he was saying that we should look at it at the federal level.
Well, I don't think you can look at it at a federal level because all the action is local. But the third point I want to make is that, and I'm not suggesting, I'm pushing Adam back, not because I necessarily disagree with him, but because I think that a lot of the people that sell single payer, it's like, oh my God, this is so bad. Oh, single payer, everything will be fine. No, it won't. It'll create different problems, and it will certainly solve certain problems. The third issue is that one of the reasons why the financing in England succeeds is because they have a long history of a very strong general practice. So at a local level, they have doctors, and these doctors, I've written about this as well, these doctors will tell the people that, mate, you cannot see a cardiologist without first coming through me. You want to see a cardiologist? I need to see you. That I'm going to make the referral. You want to see a neurologist? I will make the referral. That's not terribly compatible with America's freedom, where you have a neurologist picture on the I-76 and they advertise directly to patients. So there's lots that happens over here that's simply incompatible with, unless you just want to make single payer like this ATM, where everybody charges what they want to, where the radiologist goes to Uncle Sam and the neurologist goes to Uncle Sam. But if you are going to make it in any way similar to single payers elsewhere, you need to have a very strong general practice, family practice, primary care, not just simply people that tick the EHR boxes and say, all right, counsel for smoking, counsel for gambling, check the mental health, blah, 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 got my value-based placement. No, you have to have primary care physicians that have the balls to say you don't need to see a specialist. And I don't think American primary care physicians have the balls to say that, quite frankly.
So Adam, I wanted to comment on whether American family physicians have balls or not, but I also want to ask you a question, actually. When you talk about policy, and let's say you want to change the payment for the healthcare system, and you use whatever, the NHS Canada, whatever model, do we have enough data today to at least determine whether these models have been successful? Because obviously, if you want to create a model, you want to at least position yourself for success, however you determine success. So my first question is, A, do we have metrics of success? B, are there models out there outside of the US that are successful? C, do American primary care physicians have balls?
All right. Well, let me go through a couple of these ideas and comments. So the first question is, are there models and how do things stack up comparatively? And I think that's pretty straightforward in terms of the answer. I mean, if you look at healthcare expenditure society-wide, everyone knows this. It's a commonplace thing to say, but the US has approximately double OECD healthcare spending per capita. our healthcare spending has risen at a much faster rate than other peer high-income nations. So obviously, from a efficiency perspective, we are doing poorly and have for a long time. Of course, that's not the only thing that matters. We all know that the point of a healthcare system is not to save money. The point of a healthcare system is to improve health. That's why we're doing this. And so if you look at it from that perspective, we also do worse than many other high-income nations. Now, it is true, if you look at just life expectancy, that's going to be confounded by things that are beyond the healthcare system. But if you look at the research that has focused in on what they call amenable mortalities, or types of deaths that actually theoretically are preventable through good quality medical care, we do worse in that department as well. And so I think that, yes, in many ways, the other high income nations that have single payer systems or national health insurance systems, or various configurations thereof, have overall done better than us from a health equity perspective, from a health perspective, and certainly from an economic perspective. So I think that answer is clearly yes. I would like to turn to another point that Sara brought up, which I think is an interesting one. And I like that we're sort of moving quickly beyond sort of single payer and healthcare reform 101 and getting into some of these more arcane, but I think interesting issues. And that is what he said about the fact that even in a NHS system, even with a single payer system, that you see significant inequities geographically, right? So he mentioned that there's that there are differences in the socioeconomic utilization of healthcare between regions, that there's the hospitals with the fountains and those without, and so on. And I concede that simply passing a single payer system or simply creating this kind of system doesn't suddenly undo decades or centuries of inequity, of buildup of healthcare resources in some areas and then neglect in others. The fact that, and we saw this even with COVID. I mean, there was a study that came out last year that found that, low-income communities, about half had not a single ICU bed, whereas high-income communities, almost 100% had an ICU bed. And I don't think ICUs are the sort of perfect metric of equity, but I bring it up because we're in the context of this pandemic. And you can obviously cite a lot of other statistics of that sort. But where am I going with this? Well, the point is that a single payer system does allow you to actually make proactive steps to move towards greater equity, right? To bring healthcare facilities and resources to where they're needed to a greater extent. It's not perfect, but this is something that, famously a British, we're talking about GPs, a British GP, Julian Tudor Hart, a sort of well-known leftist primary care doctor and health policy researcher, coined this term, the inverse care law, which he, described as, quote, the availability of good medical care tends to vary inversely with the need of the population served, meaning there's more care where it's less needed. And he was talking about the UK, right? But it is also true that things that affirmative steps were made in the 70s and 80s and 90s to try to fix some of those long-standing inequities. There is evidence that some of that made a difference in terms of health outcomes. And so having a single payer system gives you tools to at least move those resources to a greater extent to areas that need them. Now, there's always going to be the sort of flagship hospitals. There's always going to be the big academic centers that can do certain procedures and certain kinds of offer certain kinds of care that are not available elsewhere. We're never going to have a situation where every community hospital offers the same things. And that wouldn't be good, because we know that particularly for uncommon, rare, organ transplants and other procedures, you actually want a high volume center. You don't want, someone who does one or two a year to be the one doing them. So the point is that, yes, so just to recapitulate, yes, there is evidence that other countries do better. I agree that single payer doesn't create equity suddenly, but it does give us tools to move resources where they're needed. Now, I do agree that as part of this shift, that we do need more of a focus on primary care, and I think that's correct. I think that we have not enough primary care physicians in the United States. I think we need more. I think we could probably use a lot less of some specialists. And I say that as a specialist, so it's no knock on specialists. And there's no reason that as part of such a transformation, we couldn't increase training of primary care doctors and potentially reduce training of certain specialists that we may have in excess of.
But Adam, how much of this a little bit cultural? Because I do think like Saurabh brings up something really interesting. Some of it is training, like you mentioned, for primary care and obviously increasing their power and making sure that they obviously say no when they say no. But the other part is a little bit culture in the US. Like the people of the US are a little bit, if I want to see a neurologist, I want to see a neurologist. Is there some cultural differences? Like we're just used that we read, if I want to get an MRI next week, I'm not going to wait 2 weeks. I want the MRI tomorrow.
So I think that a couple of things. I mean, one, look, the issue of referrals, we can talk a lot about it. I think in many cases, referrals are a good idea, right? That it can be hard to know what specialist to see. And that's what your primary care physician is there for, to take on a lot of problems, and when he or she is unable to, then refer you to the needed specialist. Now, my understanding of Canadian system is that referrals are the norm, not technically required, but far and away the norm. And you can have different kinds of configurations of that. But I mean, the reality is that referrals are needed in a lot of healthcare plans already. I mean, depends upon if you have Medicare fee for service, that's not the case. But if you have a lot of other HMO type healthcare plans, you will need a referral. So it wouldn't be that big of a change for a lot of people to have some kind of referral requirements. And I'm not even saying that's necessarily necessary. I would say in terms of waiting times, I mean, look, the reality is that for better or for worse, as you transition to single payer, we have just as many MRI machines, we have just as many orthopedic surgeons, we have just as many CAT scans, just as many lab facilities. So for better or for worse, you will be able to sort of keep up at least the same, if not increase total output of services. And so, maybe that will mean that we have higher healthcare costs relative to other high income nations with single payer systems, even if we achieve single payer. I fully admit that. But I think that's a more likely sort of outcome here than sort of envisioning that we sort of adopt wholesale a British system or a Canadian system. That's not going to happen. It's going to combine some elements of what already exists here with the financing that sort of undergirds, say, the Canadian system.
So Rob, so Adam obviously admits that it's not going to solve the inequality, but it's going to be a step forward, at least like one step, because it's going to take time until we solve the issue of disparities, if you will. But it's a step forward in the right direction. At least that's what Adam thinks. I'd like you to comment on that. And then the second thing I'd like you to address is maybe it's not just about disparities. Maybe it's about we just can't afford it. We have to reduce healthcare costs, although the last statement that Adam said, it might increase the healthcare costs. So do you really think it lowers the cost? I mean,
Well, it's hard to argue with Adam because he's very honest. And that makes it a bit difficult pinning him down. So he has said exactly what points I've raised, is that he admits that it's not going to reduce the healthcare costs, but a lot of people think it will.
He said disparities and cost, both of them.
Okay, let's start with disparity. He also admits that. Now, he believes that it's a step in the direction of reducing inequity, and I think that I can't see how it is. I think that healthcare is like an epiphenomenon. It's like the cart. If you want to reduce inequity, you need to target stuff like education. You need to get jobs, education, infrastructure. I live in Philadelphia. Adam, I believe, lives in Boston. I think Philadelphia is slightly more heterogeneous than Boston, if I'm correct. In any case, there are places in Philadelphia that honestly, they do not lack healthcare per se. And the reason I say that is because my institution I'm at, has a huge presence in West and North Philadelphia. In fact, they're actually bailing out a hospital that's failing. So it's not true that the current system, the people in these zip codes are getting neglected. I think we're not solving the root cause of their issue. And the root cause of the issue is quite simply lack of infrastructure, lack of education. And when I say lack of education, you can't just build a school. You need to get people there. You need to get the teachers there. You need to get the brightest and the best to be schooled. You need to get movement on the conveyor belt of progress. You need to, you need to have social class migration, stuff like that, stuff that England has grappled with, Britain has grappled with for the last 40 years. Healthcare comes really far down. Now, let's think of it this way. What is more important for that zip code? Mammograms or a K-12 plus education with the prospect of moving to the middle class, moving from blue collar to white collar? Mammograms is like, it's like the end. Healthcare and medical care is so insignificant, it's unbelievable. And anyone that studies net benefits and overdiagnosis realizes that its contribution to the overall, the overall well-being of society is like peeing in front of Niagara Falls, and Niagara Falls being education, infrastructure, jobs, hope, stuff like that. So I don't think that the single payer is going to move in that direction unless you have those infrastructure related things. And I'm sorry, Trump wasted 4 years of that, and Mr. Biden is wasting also time in that.
But I think, Saurabh, and I don't want to put words in your mouth. What you're saying, please correct me if I'm misunderstanding you. What you're saying is society at large has competing interests, and every society might decide what's important: building schools and parks and highways or healthcare. Am I?
No, I'm going beyond that. I'm saying that if you want to raise the well-being of people in the slums of Mumbai, don't bother with a mammogram machine. Education, infrastructure, jobs is what you need. And that's the same thing in West and North Philadelphia.
But why are they mutually exclusive? Why are they mutually exclusive?
They're not mutually exclusive, but it's when you think that one is the solution and it's not. I'm not suggesting they're mutually exclusive. You can bring the mammogram machine, but if you bring the mammogram machine and you don't bring the education, then you're wasting your time, quite frankly. And, Madam says he's a socialist. I'm actually a socialist too. I'm an admirer of Che Guevara. So I say I'm a former communist, but, we're all communists are always communists. I'm an admirer of the French Revolution. So I just think that healthcare isn't the way to deliver, equity. I think there are ways that transcend healthcare. Healthcare is just hopeless at that.
So
PET scans are not what's going to deliver.
But okay, I want to have Adam chime in here.
Yes. Okay. First of all, I don't think we should put the mammogram as the central, benefit that healthcare delivers. I mean, let's put that aside for a second. A few things. First of all, on the equity front, I just want to address this. I was conceding that when you create single payer, you don't suddenly, in and of itself, level the playing field geographically in terms of where doctors are, where hospitals are, where the PET scan and the mammogram machine is. But it does give you a tool to move in that direction. But even putting that aside, even if you didn't address those geographic inequities, the way the healthcare system is right now, who gets healthcare and who doesn't is distributed by people's needs. So if you're uninsured, you have high deductibles, you have high copays, then you are often unable to get healthcare in this country. So that equity part would be instantaneously solved by having universal coverage without cost sharing. And so that would be a giant step towards equity. Putting aside the geographic disparities issue that I do concede requires additional steps and more time. I just wanted to clear that up.
Yeah.
Yeah.
But I want to just, as you're clearing up, please address the market forces. Do you believe in free markets or not, and do they apply to healthcare? Go ahead, Adam.
So I think that market-based medicine has failed in medicine. I think that if you look at, the U.S. has one of the most market-driven healthcare systems, and it's really failed to deliver health optimally or cost savings. I mean, look, in a market-based system, healthcare goes to where it's profitable. Healthcare providers, healthcare facilities, it's means, not needs, that decides where the healthcare goes, who gets healthcare, right? But that's not how we think as doctors. We think that healthcare should go to those who need it on the basis of their medical needs, right? And so it's a totally different framework in medicine than in markets. Now, I'm not, obviously, there's going to be the operation of some markets in every system, but the reality is that when it comes to coverage, when it comes to where we have healthcare facilities, when it comes to how we distribute the services that exist, I don't think that should be determined by market forces. I think that should be determined by objective medical needs of patients and of communities.
So Rob, I have probably about 200,000 texts from you telling me markets chatters markets, and you always try to tell me that everything that's is driven in society and so forth is driven by markets. Are you saying that the healthcare system, like Adam, is not subject to market forces?
Yeah, well, I think the market, when I tease you about markets, it's not necessarily saying that I agree with the markets. It's merely saying that there are forces beyond our control. And markets, what are markets? Markets are people. I appreciate Adam's candor over here, but I don't agree with it. I don't think we're in a free market by any means in healthcare. And he admitted it earlier on in the discussion. He said that the government's already paying for 60% of the healthcare. So if you're paying for 60% of healthcare, you don't have markets. Free market where, I'm not talking about a perfect free market, there's no such thing as that. But if you want to see market-driven healthcare, you need to go to India. India has market-driven healthcare. And what you see here are market forces within a segmented healthcare. So there's heterogeneity and there's certainly market forces, but I don't think it's that clear cut. I think that if you look at somebody who is in a car accident, trauma, multi-system trauma, and they're on the M4, which is the major freeway going into London, one of them, and they're on the I-76. I would say that regardless of if you get to the point where you have somebody who is extremely poor, and this is going to really piss off a lot of people when I say this, and they're also going to say, "Oh, show me the evidence." I would say that if you did an apples for apples comparison, that person would fare better in the United States. Why? Because of the size of the healthcare, because of the infrastructure over here. The fact that you can have the interventional radiology, and I've seen this. I read trauma CTs and I've seen progression of things. I've seen somebody having a hematoma from a ruptured descending thoracic aorta, and the interventional radiologist putting a stent within 25 minutes. And you can do that because you scan left, right, and center. So I think that the redundancy of the American healthcare system is such that it benefits both the rich and the poor. And I'm not suggesting that it benefits the poor as much as the rich. I said earlier on that we have this Marie Antoinette sort of scenario, which, as Adam being a devout reader of French history will know, that the reference I'm making, give them cake, give them CT angiograms. I'm not suggesting that the poor benefit as much as the rich. What I'm saying is that, there's so much medicine over here that so much medicine kind of permeates to people across the spectrum. And I'm in a center where I read studies from a huge spectrum of wealth, from the people in North and West Philadelphia to people who live in the main line. And you know the difference because you look at the people who live in the main line and they all have a bone scan. And so I see the whole spectrum, but I also see that some good that it takes. So I'm not quite sure that it's a magic bullet for inequity, and I'm not quite sure that it's going to actually.
But
Let me.
but yeah, go ahead, Adam.
Yeah, well, just because I think a few points have been raised here. So, I mean, Sarah, first of all, was mentioning that healthcare, the overall benefits of it, sort of pale in comparison to other sort of services or other kinds of socioeconomic goods. And look, the fact is it's irrelevant because we need a healthcare system. And the question is, how are we going to design it? Now, it may very well be true that only 10% of health is, comes from healthcare. That's a somewhat random statistic that's in the back of my head. But it has made a difference. It does make a difference. If you look at over the last 50 years, there have been significant gains in life expectancy that have been the result of healthcare. It's not just about clean water anymore. That was done. And other sort of public health interventions were done, and they obviously are crucial. But improving health at this point in history does often not require healthcare, and it's not the only thing. And there are other things that matter more, and other forms of oppression that may outweigh even having the best healthcare if you are racially or economically oppressed in other ways. It may very well not be enough, and it won't be enough. But that's a separate question. Okay. I also don't think that these sorts of things are mutually exclusive at all. I mean, if you look at history, if you look at the wake of World War II, because we've been talking a lot about the United Kingdom, we'll go back there for a minute. I mean, the Labour Party delivered several things at once, and the NHS was one of them, but it wasn't the only one. And if you look at Great Society in the 1960s, it was civil rights, but it was also Medicare, it was also Medicaid. And I'm not holding up either of these moments as like perfect moments of where everything was utopian by any stretch, but there was progress made, and it was made on multiple fronts. So I've always been skeptical of the argument that there's an intrinsic give and take, that if we push for greater equity in healthcare, if we push for universal healthcare, if we push for single payer, that somehow we're neglecting other things that might matter more or might matter in their own ways. I think we can sort of walk and chew gum at the same time.
I want to shift in a little bit a couple of things in terms of cost of drugs and so on. But before I do that, I want to back up a little bit and try to simplify things, because as a listener, let me add, quick question. Adam, Medicare in its current form, has it been successful since it was created and passed into law? Would you consider Medicare as a successful system for people over the age of 65?
I think Medicare is a good program that has done a lot of good, that has a lot of flaws. The flaws of Medicare include, first of all, there is copays and deductibles that can be onerous for Medicare recipients. 2, it doesn't cover important things like dental care, eyeglasses, other long-term care. And 3, unfortunately, the way the Medicare system is structured has actually given rise to a number of very inefficient programs and financing mechanisms. So, for instance, accountable care organizations, a lot of pay-for-performance programs that really lack evidence that they're helping patients, and have evidence that they may be putting a big burden of administrative paperwork and whatnot on clinicians. Some of that has come from the Medicare program. And also the way the Medicare, this may be too arcane, but the way the Medicare system was set up back in the 60s, the way it reimbursed hospitals actually promoted a certain kind of profit-oriented growth that wound up ultimately driving up costs. And so we don't need to get into that, because it's sort of ancient history to some extent. But basically what I'm saying is that before Medicare, most seniors, had no health coverage at all. Medicare unquestionably improved financial stability and health for them. But there are shortcomings of the program that one would want to remedy before expanding it.
And you don't want to make perfect the enemy of good. So Rob, your Medicare in its current form, I mean, good enough? I mean, it's not terrible, right?
It depends what you define as good. If it's 2 to curb costs, then Medicare hasn't done that at all. And it hasn't done that because it's a blank check. It's that metaphorical blank check that your rich uncle throws to you, and you can write whatever you want. And people have written whatever they want. Medicare is the reason why radiology is so big. If radiologists ever say that, oh, I believe in the free market, they're lying. If you had a free market in the United States, you would not have healthcare this big. Medicare is also the anchor with which private insurance works. So private insurance puts their fees according to Medicare fees. So people that love Medicare are radiologists, hospitals, pharma. Pharma loves Medicare.
Why?
Why? Because Medicare doesn't have the guts to say no to pharma.
It's not Medicare, it's the Congress, no?
Well,
No,
sure,
but
but
you know,
you have a political system that is so intertwined with the medical system, that is so intertwined with the paying system. You know, when people like me have pushed back and saying, you know, take politics out of medicine, people said, oh, well, Rudolph Virchow or whatever, blah, blah, blah. Well, you know, this is the thing. You have everything intertwined. You have Congress intertwined with flipping drugs.
Adam, what do you think?
And you have radiologists lobbying to Congress for mammograms and colonoscopy coverage. This is what happens when you mix politics and medicine.
Adam?
So,
Well, I mean, first, medicine will always be mixed with politics. There's no society where that's not the case, and never will be. Ultimately, we have a healthcare system. It's going to be influenced by the political process, and the only question is it being influenced in a good way or a bad way, or a mix? And how can we push it in a good way? But I mean, I think what Zohrab is saying is somewhat closely related to what I said when I acknowledged some flaws in Medicare. When Medicare was passed in the 1960s, it was passed in a way that was friendly to hospitals and to physicians, and that helped it get passed, frankly. And yes, that has meant that it did succeed in covering seniors, but it did so at a higher cost. And it did so with sort of payment mechanisms for hospitals that encourage them to expand and to invest and to become more expensive effectively. So basically, just I keep referring to it, the initial formula by which hospitals were paid, basically Medicare covered their costs of expansion, including interest on debt they took out to expand. And that helped give rise to some of the increase in costs. But the details don't matter. I mean, we're in agreement here that to go to the drug pharmaceutical issue, as Zohrab mentioned, in 2003, when they added the drug benefit to Medicare, they explicitly said that Medicare couldn't take the steps that other countries do to keep down drug prices. So it is true that Medicare pays very high prices for drugs, which is not the case in other countries. It pays probably about double other high income nations. Overall, there's obviously some differences. But I mean, look, we can talk about this till the cows come home. Or we can talk about how we want to improve it. And that's what I'm interested in.
So, and again, I think one of the things that we're facing is no matter what healthcare system, let's face it, all of these drugs that get approved by the FDA are expensive, and they're expensive because they are priced to whatever the market is willing to bear, right? I mean, whatever the market is willing to pay, the drug is priced. And which healthcare system is going to afford these new drugs, or do you think the FDA should not approve these drugs, Adam? I mean, we have these drugs pretty expensive. I mean, not only in cancer, in the Alzheimer drug recently got approved, it's over $50,000 a month. So, what I mean, do we design a healthcare system that's going to afford these drugs because we have failed to regulate drug prices?
Yeah, so let me interject over here. I know you asked this question to Adam because I think this kind of gets to the crux of the issue, and it sort of brings a lot of the other warts all together. Adam says that you can't remove politics from healthcare, and he may very well be right, but I guess the degree of involvement is just substantial. If you have radiologists lobbying Congress to approve colonoscopy, CT colonoscopy, that's like lobbying a journal to take an article. It's really gone a bit too far. And the problem here is that because Medicare is a is a blank check, an ATM, right? And that is because politicians are too scared to regulate prices and that is because the electorate will punish the politicians if they regulate the prices, particularly the Republican ones, hands off my Medicare. It's not the Democrats, but the Republican ones. And that is because healthcare is marginal cost, is diffused to the whole population. It's all linked. It is all linked, and I'm not sure that single payer is going to solve any of these issues. Now, you could say that maybe it doesn't need to. You could say that, and there is one particular point of view from an economist who wrote a book, Baumol, yes, William Baumol. He wrote a book and he said, look, just make the other sectors productive, and healthcare could be 40% of the GDP or even 60% of the GDP. I have no problems with that. That's good for me. I'm a radiologist. I depend on third-party systems. If it was a free market, nobody would get a cardiac CT. It's because it's a third-party payer that we can buy a fancy scan and charge a bit more. But they're all linked. And this Alzheimer drug, right? I think we can all agree that it's not, it doesn't sound terribly promising, but the fact that FDA has approved it doesn't mean that doctors need to prescribe it. And here's another thing I kind of, I want to push back on Adam on is this equity thing. There's nothing wrong in denying poor people the Alzheimer's drug. Nothing wrong at all, morally or ethically. There's nothing wrong in surcharging all the rich worried well with this particular drug and letting pharma get lots of money from it with the hope that they actually make something useful that can be diffused to the rest of the population. But if you have very strict definitions of equity, then it's a case of everybody must suffer in the same way. I see no reason why poor people need to be burdened with screening mammograms. That should be taken away from them.
Let's hear Adam.
Okay, well, several things here. First of all, look, you can come up with the interesting philosophical question where if there's a totally useless drug that's harmful, is denying it to a low-income person actually a bad thing, right? But come on, it's a sort of fantastical hypothetical that no one's talking about. As long as we think there's a service or good or a drug that has benefit, that has some incremental benefit, then it should be available to people sort of separate from their means, separate from their income. And that's how the system should be structured. We can talk about the Alzheimer's drug because it raises specific questions about the sort of regulatory prowess of the FDA currently. But I want to push back on a couple other things that have gotten raised. First of all, despite what I acknowledge were the shortcomings of Medicare, currently Medicare is less expensive than private insurance. In other words, the way the market has gone, the way things have turned, private insurers are now paying, much higher than Medicare. So Medicare has managed to contain prices. If we moved, people on Medicare to private insurance, overall costs would rise. So that much is clear. Medicare does remain more efficient, and even putting aside the prices it pays to the radiologist for the screening colonoscopy, whatever example we're using, there is, and you mentioned this, Sarah, the administrative waste question. And this used to be contentious, where we use one figure and sort of opponents use other figures. But now the Congressional Budget Office has sort of ruled that our figures were correct. Not mine particularly, but sort of people who advocate for this. Less than 2% administrative overhead under traditional Medicare. Meaning 98% of every dollar that gets paid in the Medicare system goes out to healthcare, and it's more like 14% for private insurance, or somewhere north of 10%. Every dollar that a private insurer collects, it consumes in its marketing, its overhead, its administration, its profits, its CEO salaries, and its product design, et cetera, et cetera. So I know we're shifting gears to the question of efficacy, and how that affects how things should be made available. But I want to sort of reemphasize that Medicare does remain a more efficient program, fee-for-service Medicare, than does private insurance. Now, look, this is where I have a very different take on this issue. The FDA should approve drugs using a high bar of evidence. And if it does not, drugs don't meet that, then it shouldn't approve it. When it does approve a drug that has bad evidence, we can talk a lot about what the next best thing is. If this drug has no good evidence, should Medicare deny it? We can talk about that, but I don't like it. I don't like it because you're going to come up with a system that appears to be rationing on the basis of people's economic needs. I want it to be done at the level of the FDA to say this drug is effective, everyone should have access to it, or this drug is not effective. Do another trial and come back to us, and we don't make it available until then. I think that's how the system should work.
The FDA will always contend, in fact, and I've seen some editorials from FDA officials, Adam, actually Saurabh's point, and they will say, we really want to provide better access to patients and to physicians for these drugs. Some of these drugs have marginal benefit, but sometimes that benefit on an individual level could be pretty high. In other words, on a population, let's say take a population of lung cancer patients, when you look at the entire population of the lung cancer, maybe the incremental benefit is small, but when you're dealing with one patient in the room who has lung cancer, as the clinician, because you know that particular patient, there are specific parameters, clinical or molecular or whatever they are in that particular individual, that benefit could be substantially higher. So they actually always say, we will lower the bar, the barriers of entry to bring these drugs in. And then you as the clinician, you know that patient way more than anyone. You determine if you want to prescribe it or not.
I don't think that winds up working out very well. I don't. I think the FDA has approved drugs that have had minimal evidence of benefit in terms of hard outcomes, and they get prescribed. Well, why do they get prescribed? And I've heard it said, well, doctors don't need to prescribe it. So, what's that about? They're going to be prescribed. There's going to be pressure. There's going to be physicians who are less educated about that issue. It's going to just become the thing that everyone's doing. There may be financial incentives. There may be, good and bad reasons why a good or bad doctor is going to prescribe a medication that doesn't work. And we can talk about that, and it may differ at any given time or any given day of week or any given doctor. But the point is that, we shouldn't approve the drugs to begin with if we don't think they're going to help patients. I mean, that's the whole point of the FDA. And the problem is that there's been a weakening in the standards that are used by the FDA for drug approval. Obviously, there are going to be some exceptions. Obviously, there's going to be some finer points. But overall, we should have drugs approved on the basis of hard clinical outcomes, not on the basis of surrogate outcomes. Overall, we should, save those expedited pathways for really, really critical game changers. Those expedited pathways, the accelerated pathways, those are becoming the norm by which drugs are approved now. I think more than half of drugs are approved under one of the special pathways for approval. So what's that about, right? I think that we need an FDA that is more rigorous, that uses higher standards for approval, and that way we ensure the drugs that we have that are out are actually effective. Now, the question is, can we afford those? That's a separate question. And I think that we need to figure out how to make them affordable, which I think there are ways to do it. But I don't think that should be the FDA's job. I don't think the FDA should say, well, this drug works, but it's just too expensive, so we're going to deny it. I don't think the FDA should incorporate cost considerations into its determinations of efficacy. I think the FDA should approve the drug if it works. And then if that's the case, then the payer, the government under the single payer system, takes steps to ensure that it's affordable to society.
Saurabh?
Yeah, so I was wondering what the actual essence of my disagreement with Adam has been.
Well, I think what Adam is saying, what you were saying is, let the FDA approve the drug, and then the clinician decides. And Adam really contends that. He says, what?
No, actually, my disagreement is more fundamental than that. The actual disagreement I have, well, let me start off with a fact that I think all three of us will agree on, which is that evidence and treatment effect is a spectrum. It's not all or none. There is penicillin, I don't know, what do they use these days? For meningitis? Right. There's what Adam does, which is, he has sick people in the ICU and he puts them on ECMO. And there's what some of my colleagues do, which is PET scans left, right, and center, looking for rare stuff. I don't think the three of them are the same. And I think we need to recognize that. And I think, we have to think about treatment effect as being a spectrum. It's not all or none. And I have no problems with heterogeneity and inequity so long as the poorest don't get denied ECMO because they're poor, don't get denied penicillin. I have no problems with them being denied mammograms. Now, Adam will think, oh, I've just pulled something from the hat just to make a point. But I think this is emblematic of the healthcare that we have. We have so much that is so marginal. And this is the danger of using an all or none approach, because it puts everything in the same bucket. And everything is not in the same bucket. And I realize that requires some sort of quantitative figuring it out. But my point being that the whole idea of single payer as being some sort of, oh, everybody gets something, I think the equality element of it is what I oppose. I have no issues ethically. I will sleep very well at night knowing that somebody can't get a screening colonoscopy.
But Adam, do you agree with that? I mean, would you sleep well at night if you are in a system where the poor cannot get screening colonoscopy and the rich can?
Yes, I would not be okay with that situation. I mean, either a screening colonoscopy. I mean, look, it's been a while since I've read up the latest, on the mortality benefits.
How about screening CAT scans for lung cancer? Maybe you've done that.
either we should.
It's controversial. It's very controversial. It's kind of marginal. It's like, you didn't get an RCT, you didn't.
Yeah, but
I don't even know what we took. Like CT colonographies or what I don't know what we're talking about. But
well, I guess the broader question, if there's
the broader question is marginal.
But if there's a screening test that's available, look, I mean, we can all agree there is no marvelous test out there that's 100% perfect and 0% at fault. We can obviously talk about the faults of mammograms, colonoscopies, CTs everywhere. I mean, we know that. But the bottom line is, screening colonoscopy is recommended by a variety of societies, medical societies. So Rob's saying he would sleep very well at night, even if he wasn't drinking alcohol, if a poor person cannot get screening colonoscopy and a rich person can.
But I wouldn't sleep well if the poor person couldn't get penicillin for meningitis.
Okay,
that's what would make me lose my sleep.
I disagree. I think that if there's a procedure or a drug that we think is beneficial, all in all, I realize there are marginal cases. It should be available to everyone on the basis of need, not on the basis of means. I do that. I do think that. And I mean, we can talk about you can come up with these philosophical cases for useless things. I mean, look, obviously, if someone out there is doing full body MRI scans of healthy people for early detection, is that going to be covered under single payer if there's no medical evidence for it? It's not going to be. And so will that mean that some people are getting things that have no benefit because they're wealthy? Sure. But putting aside that, if there is a procedure or drug that is recommended by societies, if it's generally thought to be useful, if it's generally thought to save lives, then it should be made available to everyone. And if your problem is, I don't think that there's enough evidence for this, then that should be the focus. Then we should address that paucity of evidence. We shouldn't use rationing as a substitute for evidence.
So, I mean, I'm the moderator. I'm not going to say who I agree with, but what Adam is saying, you can't really let the wealth dictate what you would do, although unfortunately, this is a very altruistic view, Adam, because Steve Jobs of the world got a liver transplant.
Honestly,
you should never get a liver transplant for it.
I don't think. I mean, I think it's the way you frame it. It's not that people are using the wealth. It's rather saying that this is something that doesn't matter if it gets into the wealthy. I mean, particularly, what I'm basically saying is that treatment, and Adam will not disagree with this because he's a critical care physician. He knows that treatment effects aren't the same. He knows that treating ARDS isn't the same as picking somebody up from the street and saying, "Oh, let's just screen you because you might have something that'll kill you in 30 years." And that's not to say that that doesn't have a treatment effect. So I'm not putting out this whole body MRI. I'm saying that there are bona fide things that have a treatment effect that are so small, so marginal, that I have no issues for it to be just given to the rich.
But who
I'm
decides
saying-
how decides how small or how big? Like, who makes that determination?
Who beats it? We physicians. And this is why I think we need to think like clinicians. And I would say that that is a fundamental problem with using an all or none approach to evidence. And that is why we need to put our medicine thinking caps and realize that there's a very big difference. There's a big difference between a child coming in with appendicitis and this Alzheimer's drug that's just come out. Big difference.
Adam,
The difference
what
is
do you
that the problem with the Alzheimer's drug, it's not that the Alzheimer's drug has, prevents Alzheimer's or like turns Alzheimer's around, but only in 1% of the time. And you can say, well, it's like, it's a lottery ticket. At 1% of the time, it cures your Alzheimer's. 99% of the time, it doesn't. That's not what it is. We don't know that it does anything, right? So we don't know that it actually has any clinical benefit. So this isn't about a question of marginal benefits. But look, I think we can get carried away with this question. Yes, treatment effects are a spectrum. Yes, every patient is different. Yes, what works for one may not work for another. Those are decisions that clinicians must make. But at the end of the day, the FDA has to make a decision to approve a drug or not. And that decision is going to be based on, is there evidence that from randomized trials that this drug extends life or improves life for those who have it.
So let me give you one example. Let me give you one example, kind of on a global scale.
We're going to say one last thing. Once it does that, it should not, the physician should be treating everyone the same. I don't think that we should be practicing wealth sort of based medicine where we say or where we recommend one thing to one person, one thing to another. And that is where we're going, right? Because if a patient has a $5,000 deductible, you can say to them, look, I'm going to recommend the same drug to you that I would to someone with a $0 deductible, and you can do that. But at the end of the day, they may get stuck with $4,000, and they may say, well, is this the right thing to do? And I don't know what the right answer is in that situation, and it's shitty. And that's why we need to have a situation where physicians don't need to consider economic needs of their patients when making treatment decisions. I mean, that's the system I don't want to ever be in that situation.
Well,
and
I want to make a couple of points over here. First is that I think that this idea, one of the things that I've realized in diagnostics is that you have a stepwise sort of approach. You have, particularly when it comes to diagnostics in poorer and rural countries. Rural areas in poorer countries. So they can't all get a 128 detector CT scan, right? But they can get the cheapest chest radiograph, and they wouldn't have got the cheapest chest radiograph. And I realize this is hypothetical and conjectural. If the vendors didn't first sell the 128 detector CT scans to lots of, affluent places. So there's a diffusion. I know people don't like trickle-down economics because it has a lot of really bad connotations, but I think that there's some dynamic working over here. With regard to your point about marginal benefits, I think what you're saying is that that Alzheimer's drug has no benefit whatsoever. Okay, fine. I guess that might not be the best example. I'll give you another example. So there's this statin drug, as you've probably heard of. It sounds like that character from Star Wars, PKCSK whatever 9, some inhibitor, right? I don't know what the name. I can't remember the name is, but it does work. It does provide incremental benefit over pravastatin. Now, I'm taking pravastatin, by the way. No, actually, I'm taking atorvastatin. It's dirt cheap. I'm taking it. I'm not taking that PCKS whatever inhibitor. That definitely has an incremental benefit. It's like, Signal, but it has a cost. Now, I don't think there's anything wrong, ethically, morally, whatever, or even healthcare massive benefit-wise, to restrict that particular drug, knowing very well that that's an incremental benefit to the to Upper East Side New York. Let them get it. Let them get it, and let them actually make the farm.
You're promoting inequality, no? Adam?
Absolutely, absolutely. But I'm promoting inequality in the right areas.
No,
I'm saying that
Let me hear from Adam.
Wait. I'm saying that there's certain things you shouldn't have inequality over. Like you should not have people exposed to Giardia lamblia. That's not.
But you're setting the bar for inequality so low. I mean, yeah, you're saying you're saying you shouldn't have, people dying of appendicitis because fine, but that's of course. I think that we want to work towards a healthcare system that treats everyone the same. I mean, that's what I want to see. And I think that as physicians, we should practice that way. And I think that the current system ties our hands behind our back where we sometimes can't because patients don't have full coverage of what they need. And so doctors do practice class-based medicine, even if it's not what they want to do. I fundamentally disagree. I think if a drug is beneficial, we should make it available to everyone, and we should figure out a way to pay for it at a society level. Now, it is true that you can't simply have a open checkbook system where the FDA approves drugs and Medicare says we'll just pay whatever the price is, right? That's bound to ultimately fail. So that's where we have to talk about the kinds of policies that can reduce drug prices, ranging from what they do in Europe, negotiations, formularies, and we can talk about other modes of developing drugs off patent, using the NIH to directly fund clinical trials, using the NIH to directly keep drugs in the public domain. Maybe this is getting us far afield, but my point is there should be two different things. The FDA and physicians, for that matter, the FDA should decide on what's approved on the basis of the medical evidence. Physicians should prescribe on the basis of what they think the patient will benefit. And then we as a society should make the policy changes we need to control those drug prices to a level that we can afford it as a nation. And the person's individual economic means should not come into it. That's how the system should work.
Well, I mean, look, I think, first of all, believe it or not, we've been going almost for 75 minutes, and I could go for another 75. The problem is, what I've learned is listeners will not go for so long listening. So it is in the best interest to figure out some concluding remarks because I want them to hear everything possible. First of all, I would love to have you both back because you both are a wealth of knowledge when it comes to all of this. I want to conclude by having maybe 3 or 4 points that you both can agree on when it comes to the payer system in the United States of America, and maybe the couple of points that you disagree on that we probably can save for some later show. But what can we agree on? What can you both agree on? Point number 1. Saurabh, do you want to?
Alzheimer's drug sucks.
Alzheimer's drug sucks. I think Adam will agree with that. Adam, another point you both agree on from a payer perspective.
Well, I think that we agreed that implementation of a single payer system itself doesn't in and of itself suddenly level the disparities in the availability of healthcare geographically.
Okay. Any other points that you both can agree on? So it does not help disparities. Anything else, Saurabh?
It helps, just doesn't eliminate.
Does not eliminate.
I agree with Adam that there's a lot of administrative waste associated with a third-party payer, like an insurance company, where I see this all the time. We have to bill and you have to include the right views, and you have to change your dictation to get the billing. So I think there's a lot of resource consumption with the current system, which would be you'd actually require a global payment for that. But yeah, I think
so. My last question, and then I'm going to let you go. Each one will answer separately. You only have less than 60 seconds to answer, by the way. Saurabh, you are in charge of the entire healthcare system in America. you literally can do whatever you want. And what are the two things that you will implement day one of that responsibility? Two things.
I'd implement a very strong public option, the one that got killed by Obamacare. And I'd also encourage every single doctor to use their clinical acumen and say, listen, you're bloody doctors, think like one.
Adam, you're in charge. You can do whatever you want. No question asked. The top two things you will do today.
I mean, it may not come as a surprise, but I would pass and implement a Medicare for all system, covered everyone without cost sharing, and that moved sort of healthcare resources to where they're most needed, not just where they're profitable. And then I think the second thing I would do is I would really transform the way that we both approve and develop drugs. I think we could move drug development more into the public sphere, keep drugs, sort of the public owning the patents more frequently, and think about new ways to develop drugs that doesn't depend upon pharmaceutical incentives. Those would be the two things I do.
Well, gentlemen, the best thing about the fact that none of this is going to happen in the next year is that I will continue to have more talk shows and podcasts on the healthcare system, because if we resolve it today, I will have to scratch a lot of the podcast episodes I planned for the next academic year. So hopefully this will be resolved in the near future. But I want to thank you for taking time, for going the long haul. And I want to promise from both of you that you will come back in 6 months' time. Now you are on the clock.
Sounds like
Of course.
Thank you.